Thank you so much, Eve. Hello, good morning, good afternoon, and good evening, wherever and whenever you're watching, be that the recording or live. Welcome to today's webinar on bipolar research. So today we're going to be discussing current research and where the research is going. And we have three excellent guests, all of whom are international experts in research. So before we get going, I just want to draw your attention to our new research community. So if you have bipolar or are a loved one of someone with bipolar, we invite you to get involved in the research we're engaged with. If you go to bipolaruk.org and head over to the research section, you'll find our new Get Involved section to find out more. So I'm going to go over a bit kind of what Eve just said, but to note that we'll be discussing research into bipolar, but none of the information today constitutes as medical advice. Please speak to your GP or psychiatrist if you'd like further advice on care and support. If you'd like more information about any research discussed today, please email us at research@bipolaruk.org. And if you'd like more support after today's webinar, you can email our peer support team at info@bipolaruk.org. If you or someone you care for needs urgent support or help, we have created a list of crisis support resources, and they're available at www.bipolaruk.org/crisis-support. So, as I mentioned, we're joined by some fabulous experts. We have Professor Melvin McInnis. Melvin McInnis is the Thomas B. and Nancy Upjohn Woodworth Professor of Bipolar Disorder and Depression and a director of the Heinz C. Prechter Bipolar Research Program at the University of Michigan. He began his career in the genetics of bipolar disorder and presently leads a longitudinal research program in translational research focused on identifying underlying mechanisms behind bipolar disorder, as well as characterizing clinical features that are predictive of the patterns of illness. Dr. McInnis trained in Canada, Iceland, London, and Baltimore. He is a fellow of the American College of Neuropsychopharmacology, the Royal College of Psychiatry, and the Royal Society of Medicine. Dr. McInnis leads the efforts to establish a global bipolar cohort, a collaborative of researchers and stakeholders focused on longitudinal clinical research in bipolar disorder. We are also joined by Jeremy Hall. Jeremy Hall is a Hodge Professor of Psychiatry and Neuroscience at Cardiff University. His overarching interest is in the role of genetic and environmental risk factors in the development of serious mental illness. In his work, he employs a translational approach spanning human and laboratory studies. He is particularly interested in how identified genetic risk factors affect learning processes in the brain, abnormalities in which underlie key symptoms. Overall, he believes that understanding how genetic risk factors influence the brain and how these responses are modulated by environmental stimuli is crucial in the development of new treatments for psychiatric symptoms. In addition to his research work, he is also clinically active and conducts clinics in neuropsychiatry. Last, but certainly not least, we have Dr. Tania Gergel, who has just started a new role as the first director of research at Bipolar UK and is also an honorary senior research fellow in the Division of Psychiatry at University College London, Cardiff University Medical School, and King's College London, specializing in mental health ethics and law. The primary focus of her research has been on the clinical, legal, and ethical issues surrounding the creation and use of advanced directives in severe and episodic mental health conditions, in particular bipolar, and she has worked in partnership with the Department of Health and Social Care on the upcoming introduction of statutory provision for advanced choice documents within the England and Wales Mental Health Act. Her work focuses on putting lived experiences of mental illness at the center of mental health research and policy, and is internationally recognized for her work on advanced directives, electroconvulsive therapy, and co-production. So thank you for letting me just kind of run through the list of introductions and biographies. So my name is Dr. Talen Wright, and I am the postdoctoral research manager at Bipolar UK, and I look after the kind of day-to-day running of the research. So first, we're going to be speaking with Professor McInnis. So hello, Melvin. Are you
hello.
Around?
Yes, hello. Hi.
How are you?
Well, thank you for the invitation to participate in this. I'm very honored to be here.
Oh, thank you. So can you tell us a bit about yourself and your work?
Well, thank you. So as you noted, I began my career in the genetics of bipolar disorder. And like many of my age group and cohort, we were very convinced that we would be finding genes for bipolar disorder very quickly and very easily. As it turned out, it was far more difficult than we ever anticipated. And around 20 years ago, I relocated or was recruited to the University of Michigan, and I saw that as an opportunity to really to recalibrate my research approach and focus on identifying identifying individuals with bipolar disorder who wish to work with me in a longitudinal study in order to learn more about what causes bipolar disorder in the sense of what causes people to become ill, what are the features that promote wellness, and to engage individuals over time to study a wide range of features related and associated with the illness. So that is what I've been doing for the past 20 years here at the University of Michigan, really collaborating with people with bipolar disorder to understand more about the pattern of the condition and learn more about what we can do.
Oh, that's really interesting. Can you just explain to us a little bit, like, what does longitudinal mean? What is longitudinal research?
Thank you. So that means that we're engaging individuals over time. So we have regular touch points with them. We're now using more obviously online methods for individuals to fill out an assessment of their symptom severity, how things are going, what issues are going on in their lives, if you will, over the course of time. And on an annual basis, we have a touch point with them where we have an interview to hear more about their experiences and to develop a narrative of the course of their condition over the year.
Oh, amazing, thank you. And can you tell us a little bit more about the global bipolar cohort?
Yes, so the Global Bipolar Cohort is a collaborative of individuals worldwide that have an interest in bipolar disorder. So these are primarily researchers and clinicians throughout the world that are meeting monthly. We gather together online to learn more about the groups of individuals and the cohorts, the study groups around the world that are focused on bipolar disorder. So we're asking questions like, what is bipolar disorder around the world? What are the functional outcomes of individuals who live with bipolar disorder around the world? What is the variability in treatments of individuals, around the world? So we're working together to study the patterns of bipolar disorder globally, but also to identify and work with other individuals that are focused on developing a common language by which we can compare individuals with bipolar disorder. So one of the things that we've learned in the Prechter bipolar cohort is that there are many facets, there are many ways to approach bipolar disorders. You can look at it purely from a disease perspective, when you see an individual or in the presence of an individual in an acute manic state or an acute depressed state or in a mixed state, it is appreciated that there is likely something going on in the brain of that individual. There's some biochemistry that's different there. But equally importantly, there are other psychological features of the individual that are worthy of study. And those include, for example, the personality construct of the individual, who they really are, their capacities and their just ability to function, their what we refer to as executive functioning. Additionally, there are behavioral aspects, what the individuals eat, drink, and smoke. So substance abuse can exacerbate bipolar disorder in a very profound way. Further, there are sleep and circadian patterns that are worthy of study. So individuals with bipolar disorder often are out of sync, with the normal routine of the day, waking late into the night or so on and so forth. Life story issues. We all endure life story issues, marriages, going to schools, birth of children, divorces, and so on. So all of these things need to be studied in a very focused way. The final thing that we're very excited about, both here at the University of Michigan and with the Global Bipolar Cohort, is to study the pattern of symptoms and the change patterns of individuals living with bipolar disorder over the course of time. And we're finding, for example, Talen, that significant proportion, say 15, 20% of individuals with bipolar that live with a bipolar condition, their mood states are going up and down very frequently. And so these individuals live with constant change in their symptom patterns and so on. So that, to me, is singularly one of the most compelling questions in bipolar research is, why are some individuals very unstable and moods are up and down? Why are others more or less, stable for periods of time until they're not, and then they get into a state? And what causes these changes? So there are many truly compelling questions in the field of bipolar disorder, and so we realized that in order to work on and solve or begin to solve these questions, we need the collaboration, we need the energy, we need the enthusiasm that's going on worldwide. And there's so many people interested in bipolar research. Many a time, these individuals are, they're alone, or they have a small group, in institutions worldwide. And this is a way to bring people together and collaborate. We love to collaborate.
Yeah, no, absolutely. And I think that some of the things you said there are really, really interesting. And I kind of want to pick your brain a little bit, I suppose, about maybe some of those theories you have about why the kind of the sudden fluctuations you were mentioning, why that might be occurring, and kind of what research is currently happening within the global bipolar cohort that may be looking into that.
Well, that's a very interesting question. A why question is always, I think, the most difficult question that there is. The first thing that we're interested in looking at is to be able to describe what's going on, and then to be able to identify individuals for whom there is considerable fluctuation. And the first thing that happens in science is to start to look for factors that are related to or associated with these changes. Now, the fact that something is associated with a change does not at all mean that it's causal. And so individuals that live with bipolar disorder, in my clinical experience, I'm interested in Professor Hall's perspective as well, that these individuals are frequently more reactive in the sense that a positive event will get them more excited, gosh, it's really great. Or a negative event will draw them down a little bit more deeper than the average, than would be expected, if you will, in the world. So there's this reactivity among individuals that live with bipolar disorder, and this reactivity is present even when they are not in a manic or depressed or mixed state.
Okay, that's very interesting. Thank you. And as you work with the international research community, can you tell us what really stands out to you as global similarities and differences with bipolar?
Thank you. So I think that the similar features are the extreme states, and so the feature of mania, of elevated energy in the manic state, and the diminished energy in the depressed state stands out as being among the more common features across the world. What the differences are driven in part, I believe, culturally, in the sense of how quick people are to seek care. And this is really just from the impressions of talking with the researchers globally. They will say anecdotally, well, we have a hard time because people are so stigmatized in some cultures because of the illness. And so many, for example, Asian countries, there is a greater frequency of complaints of physical headaches or things like that. In other societies, there is an attribution of almost kind of spirituality related to the manifestation of the symptoms. And so all of these are in the background contributing to the manifestation or the presentation of the illness. But it is clear to us that there's this common form, the common form, if you will, is this energized state. And so when I talk to patients, family, students, and whoever wants to listen to me, I talk about the energy of bipolar disorder, that it is a pathology of energy. There's something different in the energy state of the individual with bipolar compared to the average person.
Yeah, no, I think that's absolutely fascinating, and it's something that I have heard about before. That sort of kind of, I think the word some people might use is somatization. Is that sort of like the embodiment, the body
Yeah.
feel of mental
I'm
distress?
feeling bad. Something must be wrong with my body. I feel I've got a headache, or my stomach hurts, or my bones hurt, or I've got everything, everything is hurting. So therefore there must be something physically wrong with me.
And I think that when we're talking about clinical practice, working with people, um, it's having that sort of culturally adaptive practice, right? It's being able to notice these things and understand what it means to the person, rather than
Very
kind of
important.
being led by our own kind of presumptions about illness and what illness means. Um, what do you think is the most exciting development on the horizon for bipolar research?
Well, I think firstly, there are many exciting elements, and it will depend on with whom you're speaking to give you an impression and an opinion on it. This kind of a statement is really truly an opinion. I think that one of the more exciting elements that we're studying at this moment is the study of features of bipolar disorder that will allow us to predict or anticipate when an individual is headed for difficulties. And there are a number of methodologies on the horizon, and this includes the machine learning or the artificial intelligence, or looking at large bodies of data. I think that's very challenging and very interesting, and it's going to require a considerable amount of rigor. Can we replicate these findings in independent samples? And that I also think that at the biological level, there is and remains a considerable amount of enthusiasm at the level of genetics and neuroimaging. And the question is not whether these are going to solve our problems in understanding bipolar disorder, rather, what is the contribution of genetic research to understanding bipolar disorder? What are the contributions we're going to learn from all of the imaging studies and that? And equally importantly, what we need to do is focus more on the clinical elements of it. What are the clinical features? How do they vary, and how can we study them over time to be able to anticipate changes in bipolar disorder? It's an anecdotal story. One of my family, one of my patients said, Dr. McInnis, when I was seeing the patient in the emergency room, they said to me, there was something happening 2 weeks ago. I could just hear it in their voice. There was something about it and that. So can we identify these subtle, nuanced features amongst individuals with bipolar disorder to give us a likelihood estimation, if you will, as to whether they're going to develop mania, depression, or run into other problems?
Yeah, I mean, that sounds to me like it's heading possibly towards something that's highly personalized, talking about kind of like people's individual behaviors and how that might signify that something's happening, something's changing. Some people, as you said, like there's maybe something in their voice, but for other people might be in just how they're generally behaving. And that would be really interesting to see kind of how that could predict, episodes maybe, or knowing when to ask for help potentially. We have time for like one more quick question. So you kind of already, I suppose, answered it in a way about what is in the future for bipolar research, but do you know of any pressing research gaps that we should be addressing right now? Something you mentioned, I think, was about the sort of kind of symptoms and
Yes.
focusing more on symptoms.
Yeah, I think that one of the more pressing research gaps right now is the ability to find a common language, a common data model by which to compare data samples across the world. And so we're working with groups of investigators. One of the teams that we're focused on working with right now is called the Human Phenotype Ontology. And so this effort is looking towards identifying a common language, a lingua franca, if you will. So how can we compare a data set in country A versus a data set in country B, even though those data sets have different methods of assessing individuals. And so if we can map them to a common dictionary, if you will, I think that is going to help us enormously. And I'm very privileged and excited to be working with the team that's focused on this.
Thank you. Yeah, that's sort of, yeah, ontology. Can you remind me what ontology what means?
Ontology is what is. So it's just asking a question of what is, what is bipolar disorder? And that, that Talen, that is a far more complicated question than meets the eye, and just what is bipolar disorder is a challenging question.
And as you said, it's kind of finding that common language
Exactly.
in different countries to say this is what bipolar is, I suppose. Well, thank you so much. That's our time with you, Melvin. Thank you again for joining us. Next up, we're going to be talking to Professor Jeremy Hall. So, hello, Jeremy.
Hello, everyone. Thank you very much for inviting me. And it was lovely listening to Melvin, and I really enjoyed that, Melvin. Thank you.
Yeah, it was great. So, thank you for taking the time to join us today. Can you tell us a bit about yourself and your work and what you do?
Sure. So, hi, everyone. I'm an academic psychiatrist. I'm based in Cardiff, where I run the department of psychiatry and neuroscience. I'm also a keen gardener, a singer, and perhaps slightly more unusually, a recorder player. So, I have a life outside academia as well. I trained originally in biology before going into medicine. And I then, I kind of moved around a little bit doing my medical training, but in terms of training in psychiatry, I did a lot of that up in Edinburgh, actually where I am now, and because I have family up here. And I was trained by a lady called Eve Johnson, who I expect Melvin would have met over the years, and others, and she was a great mentor to me, and that was a very good experience. But it was frustrating at times. I was frustrated by the difficulty we had really diagnosing people reliably and getting the right treatment to the right people soon enough. And so that led me to, although I always really enjoy clinical practice and I still do undertake clinics, it led me to doing more research to try and kind of address some of these issues, because it seemed to us, as Melvin was really pointing to, there's so much that we still needed to understand and tackle. And then in about 2013, I moved down to Cardiff and joined a great group of investigators there. A lot of strengths in genetics, but since then, I've been really enjoyed being part of also building the neuroscience environment linked to that genetics, and we set up an institute for neuroscience and the like. And so it's been a very exciting journey, and that's what we continue to do, really.
Amazing. A recorder player, really?
Yes. I have several different recorders.
That's amazing.
That's a different webinar.
Okay, great. Well, can you tell us a bit more about transdiagnostic research and precision psychiatry? What does it mean, and why is it so important?
Yeah, I mean, we know, I think everybody knows, and Melvin, alluded to this as well, that people respond differently. We have categories, diagnostic categories like bipolar disorder, but there's a lot of variation within that category and a lot of very, kind of commonalities across that category to other diagnostic categories. And so, we don't have great precision in what we can give people in terms of diagnostics, prognostics, or treatments. And that's frustrating for everybody involved, really. So, I guess a reasonably good comparison would be with something like cancer, where, in the past, we have very general treatments for cancer based on just kind of the organ of origin of the cancer. And now that's changed, and people have much more specific diagnosis for their cancer and much more specific treatments in many cases. And really, I guess what we mean by precision psychiatry is getting to that kind of level of precision in mental health care as well. And I think we lack that at the moment, but there's some really exciting suggestions that we can pull out, more precise categories of people, more precise causes, and they would hopefully lead us to better treatments quicker for people. So that's the kind of mission, if you like.
That's a really great way of explaining it, because when I started out in this field, I didn't really know what precision psychiatry really meant, and it's that sort of notion of finding things that are targetable, specific, kind of getting drilling down, I suppose, into it, right?
A lot of our treatments are, I love being a psychiatrist, but you've got to be honest about it. It's a lot of hit and miss. There's a lot of not being sure if this will work for somebody, and wouldn't it be great if we could, refine that process and say to somebody more quickly that we feel this is likely to be the right treatment for you, and get improvements more rapidly. That's the target. That's what we're
Yeah, exactly. And it feels like that is the kind of natural progression of science more generally, right? You kind of get the big overarching issue, and then you start getting more specific once you have that evidence. So I'm just looking at my questions. So you've made it a priority at Cardiff University to involve Bipolar UK and other partners within the research you're conducting. Why do you think this is so important? And what do you think it adds to the research?
So it's been great working with Bipolar UK. Tania's on here today. I've really enjoyed working with her, and I know that other colleagues like Ian Jones have worked with Bipolar UK over many years, and it's been brilliant. So thank you all. From my perspective, there are lots of different angles to this. So excuse me if it's a slightly longer answer, but first of all, we can't just sleepwalk into the future. We have to look at this together. We have to think together about what we want psychiatry in the future to look like and how we can change it. And let's be honest as well, psychiatry hasn't had a brilliant history of doing this all the time along the way. So let's not repeat the mistakes of the past, and let's work collectively. Let's think together about what the real issues that people face are and what they want research to be directed towards and targeted towards. And, it's amazing that we didn't do more of this before, and it's really invigorating and exciting doing it now. And some people have done this for a long time, but it hasn't been uniform. I think we can work together to advocate for the importance of research, and we've really seen that with bipolar disorder and Bipolar UK. I mean, just to give one example, by working with Bipolar UK, Ian has been able to involve more than 7,000 people in research into bipolar disorder. That's fantastic. That's really, really a huge achievement. We can help together to work on kind of less well understood conditions and to tackle elements of stigma. Think of some of the work that's been done around, for example, postnatal psychosis and bipolar overlap, where bringing more public awareness in that area is so important. And I know Ian's worked with you on that as well. And different kind of interventions, things like, accessible interventions like, online psychoeducation is something that we've worked on together between Cardiff and Bipolar UK as well. And that's been taken up really well. So there's just a whole range of different areas that I think we have been working together and can continue to work together.
Thank you. And yeah, I think that, when I joined up, it made sense to me, this sort of notion of co-production and highlighting, I suppose, like working with people with lived experience, not only in what we think we should do, but also for them to say what we should be doing. So, for instance, things like postnatal psychosis and bipolar would have been heavily disregarded for probably many years, decades, even centuries. And until people start pushing for these sorts of untouched, I suppose, territories of research, we kind of miss out on it.
And having better public awareness of that is, they're very challenging conditions for people to be presented with in their lives, themselves or other people. And if we can raise awareness and understanding, then it can help people through those very difficult phases, even before we improve therapies.
Exactly. And so can you tell us a bit more about the work on bipolar and psychosis that you're going to be leading with bipolar? So I'm thinking like the SW2 hub might be worth plugging at this point.
Yeah, sure. No, I'd be happy to talk about some of the work. Tania's involved in this as a co-applicant, and it's been great working together. I should point out that we have a pretty flat leadership structure in Cardiff, so I wouldn't want to give the impression that I'm leading this all on my own. There's colleagues like James Walters and Ian and lots of other people involved. So we work as a team. But to talk about that particular project, again, this is really coming back to trying to get more precision into a diagnosis for more major mental health problems, including bipolar, but also across other psychotic conditions like schizophrenia or schizoaffective disorder. And the biggest part of this, so this is part of the UK's new investment in mental health platform and supported by the Medical Research Council. So they set up 5 hubs across the UK, and one of those is led from Cardiff, but involves other universities in the southwest of England and in Wales. And what we're really looking to do is to study at scale people with bipolar disorder and, as I say, other psychotic conditions. We're going to conduct, it's very much kind of the type of work that Melvin was talking about earlier, some detailed imaging analyses, cognitive analyses, and genetics, and really trying to look at this question of, are there better constructs that go across diagnoses? We've been informed a lot by work that you'll, I'm sure, be very aware of, Melvin, from the BSNP consortium in the States, and we're wanting to really build on that. That does suggest that there are what they call biotypes, groups of people that perhaps have more similar underpinnings to their condition, but are not, that these span across the current diagnoses. So we need to really get a better handle on those. And something else that Melvin referred to earlier, and I think so important that, perhaps hasn't been so prevalent in the past, is not being afraid of doing things to replicate things, to show that they're really reliable. They're reliable in different populations. They're reliable in different circumstances. So we're trying to build on that work done by BSNP and see if we can build on it, but also replicate it. And I think that would be a very, very important piece of progress, to be really sure that we're getting down to better, more precise groupings of people. And we're really working closely with Tania on that, and other partners, other people, groups representing people with lived experience, understanding what they feel are important features of their presentation and what we can include in our analysis, and seeing how we can best engage people in the project.
Yeah, thank you. Yeah, I mean, what you mentioned there, I think there's something to be said about, if I'm remembering correctly, it's just completely gone from my mind.
Don't worry, that happens to me all the time, Talen. It's actually quite reassuring to see it in somebody else, so it's not just me. So thank you for that.
So right, so we've got a couple of minutes left, and I think that you kind of touched on it about lived experience and priority setting. So I think it's quite good that we kind of mention this again. But a lot of the work that you do does center on genomics. So that's genetics, neuroscience. To be honest, I might need you to explain genomics a bit more for me, because I don't quite understand genomics. But this is oftentimes felt removed from lived experience and priorities. So can you tell us why it's so important that we don't neglect these issues and how it relates to our members?
Yeah, so loads of things to say here, and I'll try and keep it fairly brief. The first one is that I also sometimes get confused about genetics and genomics and all these different things, but basically genetics is studying genes, and genomics is doing that at big scale, like all the genes.
Yeah,
and I don't think any of us. The other thing to say is I'm not a geneticist, but I kind of understand genetics and I work with lots of geneticists, but I'm not a geneticist myself. But I think it's really important, and I think it's important because as Melvin was alluding to earlier, it's tricky getting a handle on kind of causative processes in conditions like bipolar and other mental health problems, and we need to try and choose some way to give hints so that we can begin to improve treatments, improve diagnostics, and the like. And the good thing about genomics, which is looking at genetic variation across all the genes basically in a person, is that it gives us one way into that. It gives us a way of understanding, what might be some of the biological risks. And the really nice thing about it is that we can measure it, and it's not easily kind of confounded, if you like. It's kind of it's there from the beginning, so you can really kind of take some faith in it. As Melvin said, it's been very difficult looking for genomic risk factors and that's because it turns out to be really, really complicated. But colleagues, and I don't take credit for this myself, but colleagues, have made fantastic progress with this recently, and that gives us some insights. You can begin to look at the genes that are implicated. You can say, well, what do they do in the brain? And that gives you some clues as to where to look. I guess an analogy would be, people used to talk about respiratory diseases and say you had consumption, and you were ill because you had consumption. Nobody really understood what was going on. Then you had Pasteur and Koch and all these people who said, there are bugs that can cause diseases in the lungs, and that might be why. And then eventually you get treatments because you have antibiotics or whatever. And we're at a kind of much earlier stage of that process, but we have to understand some of those causal factors. And genetics is one way in. Just one more thing, because I don't want to go on forever, but I don't think genetics is like the end of the story at all. It's just part of the story. It's part of the story for lots of reasons. One thing, again, Melvin mentioned earlier, is that I don't think any of us think that these things are just caused by genetics. It's just one part of the clue. It's just something you can measure. But obviously, what happens to you in your life, interactions, other risk factors are really important too. And we can kind of begin to look at the interaction between those things. And genetics in the end is statistics. And we need to use that information not to just be statistics, but to actually inform biology, inform understanding of changes in the brain. And that's kind of the interface that I'm really personally interested in.
Yeah, no, absolutely. And I think that what you mentioned there about genetics not being the kind of end result to all of this, and it's just part of the story. We talk about the biopsychosocial model,
Exactly.
and so it's taking in consideration, all the biological factors, all the genetic factors, the social factors, and the psychological ones too, to kind of build a better picture, right? And I think that will lead us into better precision, of course, because if we know these factors, we know what's going on, then we can be more tailored in our approaches, and people will have better outcomes as a consequence.
Talen, I could not have put it better than the way you just put it. That was a fantastic summary. Write that down.
Like recorded, apparently.
Amen to that.
And just final question, there's still about a minute or so left. This one comes from the kind of part of the puzzle with the community questions that I didn't mention earlier, but it's kind of ways that neuroscience can advance treatments in the future. So what do you think is kind of going on there?
So there are quite a lot of exciting things going on. As Melvin also mentioned earlier, it's tricky to pick out, one thing. But maybe just because we're short on time, I've got a minute, so I'll just choose one. But please don't take this as being the only thing. There are lots of exciting things going on. But one thing that's quite exciting is that, one area that's been really tricky is that, as people who study the brain, it's very hard to kind of directly access the brain. It's in a box, and it's difficult to get hold. And you can do brain imaging, but that's a bit of a step removed in some ways, although it can be very valuable. So one thing that's been quite exciting recently has been the use of what we call induced stem cell models. So basically, you can take a sample of somebody's blood or maybe a tiny little skin sample, and using advanced but tractable methods, we can then turn those into brain cells. But they're the brain cells kind of from that person. They've got that person's genetics, and we can grow those in a culture. And why does that matter? Well, when I was training, we had no way of really understanding what was, maybe different in the cells of, somebody, who was suffering at that time from a change in mental health. And now we perhaps can look at that. And that's really important because that gives us a readout that we can look at things like treatments, that might be effective for people. That technology is still quite early stage. There's still lots of challenges with it. But I think being able to study somebody's brain cells directly and ask these kind of scientific questions is really a change from where we were at before. So I think that's an exciting frontier for us.
Sounds very science fiction.
I know, but so just to reassure everyone, you can't build a brain from these cells, not in the kind of normal way. You can study how the cells like fire and stuff. Okay. Although you can get them to play the computer game Pong. There is actually a paper out there that shows that. But it's a very simple computer game.
I'm into that one. Thank you so much, Jeremy. I think that's all the time we have for you. And now we're going to move on to Tania Gergel. Dr. Tania Gergel, hello.
Hi.
How are you?
Yeah, good, thank you. Thank you so much. And thanks so much for Melvin and Jeremy for joining us today as well.
Yeah, it's been absolutely fascinating listening to these talks, kind of still marinating in the brain a little bit. But can you tell us about yourself and your work?
Yeah, so very briefly, I started off as a philosopher, and that's what I was doing for a long time in my life. I was lecturing in philosophy and mainly ancient philosophy. I was taught Plato, of all things, at King's in London. And then there were various twists and turns in my life and my career. And somehow or other, I ended up coming into the area of medical ethics and especially mental health ethics and law. And that's really been me for the last sort of 13 or 14 years. And gradually that's increased into sort of more work, empirical work, more clinical work in psychiatry and psychiatric research, lots of stuff branching into neuroscience, into psychopathology. So still with this still with a very much an emphasis on ethics and law, but very much also looking at other elements of clinical work, and especially since joining this particular role, needing to rapidly become an expert in so many fields that it's a long way from philosophy, although not very far from philosophy too, because I always find that philosophy is at the center of everything. The other thing is that I myself have bipolar, and it's a huge privilege to be able to work in this field and see it from so many different perspectives. And the other thing is that in all my work that I've done in this field, I think that the highest emphasis is putting lived experience at the center of work, whether that's people with lived experience taking part in research, co-production, or whether that is research that really focuses on putting the experiences of people with lived experience at the heart of how we understand mental illness. That's at the core of what I do.
Yeah, absolutely amazing. And I know that you want to talk today about mixed states. So can you walk us through what mixed states are?
Yeah, actually, I think a great segue for that is what Melvin said earlier on. I love Melvin's characterization of bipolar as a pathology of energy. For me, definitely, that would absolutely hit the nail on the head. And I suppose for mixed states, that's particularly true because I think mixed states, if bipolar is a sort of pathology of energy, mixed states are essentially when that energy kind of goes a bit wrong, to put it very simply. So when people talk about bipolar, they talk about episodes of high mood and low mood, especially as we call it now bipolar rather than manic depression. And if you look at mood scales, typically they sort of go from severe depression at the bottom through to kind of euthymia or feeling well, through to mania, as if, there was a sort of these two poles. But we also know that for so many people with bipolar, that is a lot of the time or some of the time just not how they experience it. And instead, it's much more complex and it's much more a combination of different elements of high mood, different elements of low mood. So if we think about it in terms of psychiatric classification and we go to the sort of so-called Bible of classification, the DSM-5, it characterizes mixed states as essentially if you have a state of depression and you then experience three elements of mania or hypomania at the same time, or conversely, if you're having a state of mania and you experience three elements of depression, then it would qualify as a mixed state, which sounds neat, but unfortunately, it doesn't necessarily translate that well into the reality. And the research suggests so far is that things just aren't that simple.
Mm. Okay, well, yes, absolutely. And can you explain kind of what you mean, I suppose, by
I
mixed
think
states?
so. So what I mean by things not that simple is that mixed states really they're more than the sum of their parts. And when people talk about something called mixity, the idea that actually, if we go back to the old notion of manic depression, that's really more kind of more suitable. That this is something, it's not as simple as saying, well, you've got two features of depression at the same time as two features of mania, but that actually it has its own character, that mixed states have their own character. A key term that comes up a lot is something called dysphoria. And what that means is that you're experiencing a sort of an extreme mood state, but in a way which creates severe mental unease or discomfort. And I think that's the really key thing about mixed states, that they're predominantly a negative experience. There may be positive moments within them. They're predominantly negative. Yeah.
Mm. And then what type of things do people experience?
So the key things that people experience, I'd say above all, the thing that people characterize as racing thoughts, and then this excessive and uncontrollable energy. Then I know we were talking about this the other day, you and I think that one of the things that isn't mentioned enough is just this continuous sense of overstimulation, just something that's not able to be controlled, as if someone's got an engine inside them that's just gone out of control. That's how it. People talk about something called psychomotor, not enough, but they should talk about it more, psychomotor agitation. And this is once again coming back to what Melvin was saying about the somatization, the sort of physicality of things. So mixed states are experienced very much, they're inside the mind, but they're experienced very much physically within the body. And it's as if this compulsive need to keep moving, and it's driven by tension and agitation. People sometimes talk about it in relation to irritability or anxiety, but it's not the same as normal irritability or anxiety or agitation. It's much more physical sort of sense of just this relentless energy that's pouring through you that you can't control and makes you feel sort of, it can create claustrophobia, agoraphobia, things like you can't, and a sort of just that huge physical and mental discomfort. And so, for some people it has a lot that there are sort of, it almost divides into two different experiences. For a lot of people, it will be more in common with mania and hypomania, so it's very sped up, and so there's a decreased need for sleep, there's a lack of inhibition, you're seeking out stimulation, and often, flights of grand ideas, lots of confidence, that type of thing, but then it's sort of flipping rapidly into that kind of going very wrong. Often there can be psychosis, so you can have delusions as well, and that's coupled with the types of delusions which can be fantastic or can be terrifying or can flip between fantastic and terrifying. For other people, some people experience it more as what we might call agitated depression, a sort of mixed depression, and there it's really more that there's this sort of the loss of energy and the low self-esteem, the kind of hopelessness that we associate with depression, but also that's combined with this intense and sort of often intolerable mental energy. So those really are the key features of the experience, I think.
Yeah, it sounds incredibly difficult to deal with in terms of, as you said, like having that really, in terms of like agitated depression being so low, but just feeling like you can't quite settle.
Absolutely. I think it is. I think it's a state of just psychic discomfort. And also, I mean, quite unsurprisingly, I mean, well, I'll talk later perhaps about that more, but it is the state that is most associated with feeling suicidal and with suicidal behavior and suicide in bipolar. And it's really because I think this sort of physicality of it and the sort of loss of control of this internal agitation, and that psychomotor agitation that drives towards self-destructiveness, combined with all this kind of this flipping mix of depression and mania and psychosis, and it's really a sort of a kettle that's boiling out of control. Yeah.
Absolutely. And how common are mixed states, do you know?
Probably a lot more, certainly a lot more common than would be thought by the amount that they're discussed. So we don't know completely because the research into mixed states is very limited. We need to make a lot of progress, but generally people say that at least 40% of people with bipolar will experience a mixed state at some time, and we do think that it could well be as high as 80% of people with bipolar. So certainly something that the majority of people with bipolar will experience some type of mixed symptoms at some time, and yet nobody, it's this thing that people aren't talking about.
And on that point, as you said, that we're not talking about, so what do we know about mixed states? But maybe more importantly, what don't we know about mixed states?
So I mean, I think what we do know is we know the association with suicide and with suicide risk. We know this association towards self-destructive behavior. But what we don't know enough is why, and we don't have an understanding of what's happening when that happens. That's what we really need. We know that it's very common within mixed states to overuse alcohol or drugs, or other forms of compulsive behavior. We think people are essentially self-medicating to control the agitation and also, manage the stimulation and kind of keep that under control. But once again, we don't know exactly why, and we need to know much more about that. We've got lots of research which says the same things about mixed states, but the key thing that the research on mixed states says is that we need more research on mixed states, because what we don't have clear clinical guidelines. We don't, people have been talking about mixed states since antiquity, since Hippocrates back in 2400 BC, and yet we don't have clear clinical guidelines about what mixed state is, going back to what Melvin was saying, needing to know actually what things are. We don't know what they are exactly, and we certainly don't know clear guidelines for how they can be recognized.
And what about treatment?
So treatment, once again, we should have better knowledge. Because of all the limitations in our knowledge of mixed states and all the limitations in the treatment options that are now available for psychiatry in general, there are massive limitations really. What we do know, four things. The most important thing is that mixed states are often misdiagnosed as unipolar depression, just as depression. And this can be really dangerous because then the typical treatment is antidepressants, things like SSRIs. Now, if you give an SSRI to someone who is in a mixed state, then what this can do is it can worsen the mixed state. If you give an antidepressant to someone who has bipolar, it can induce a mixed state. Antidepressants typically are there to, depression causes a slowdown and a loss of reactivity and all of those things. If you give that to someone who has a tendency or is experiencing an excess of those things, you can imagine that it can go horribly wrong, induce mania, induce hypomania, induce mixed state. We know antipsychotics can, then what we have to do is we have to use the means that we have available to try to slow things down. So the ways that we can do this, we use antipsychotic, especially quetiapine and olanzapine. They can be helpful, sometimes in combination with mood stabilizers. We know lithium itself, which is the sort of golden standard for bipolar, isn't actually, isn't that effective for mixed states by itself. Benzodiazepines can be useful in the short term for treating mixed symptoms because, once again, they slow anything that can slow things down. Medication that can help people sleep, sleeping medications, things like Zopiclone, things like that. And then finally, for the most severe mixed states, especially when there's psychosis involved or when someone's very suicidal, a treatment which is incredibly effective is ECT. Once again, it's really underused. People don't typically think of it in this context, but it has been shown to be enormously effective. There isn't a perfect option, and we definitely need much more research on treatment. One thing outside of medication, I would say exercise is enormously useful. Someone is surging with mental energy, and anything that someone can do, although you have to be careful because with many you can take this to excess. So, the sort of surging energy of many can take this to excess, but within reason, exercise can help to control some of the symptoms of mixed states. And it doesn't have to be, formal exercise. It can be as much as just going out for walks, being in the fresh air, being in open spaces, being away from excess stimulation, screens, getting physical, that sort of thing.
And why is this important? I suppose is a good question to ask.
I suppose if I had to say why it was so important that we know more about mixed states and do more to understand mixed states, I'd highlight two key things, and that really is that would be suicide and delayed diagnosis. So we know suicide rates are very high within bipolar, shockingly high, and we definitely think that mixed states carry the highest risk. But we understand so little about mixed states, and I think that, if we could increase our understanding of mixed states, this would be a huge step towards, potentially beginning to understand more about suicide and bipolar and finally beginning to be able to reduce the rates of suicide. Then there's delayed diagnosis, which ties in with both of those things, really. We know that bipolar is, typically not diagnosed for many years after the first time someone seeks help. So for Bipolar UK members have said that that's averaged 9.5 years. For me, it was about 15. Global averages suggest between 8 to 10 years from first coming to a medical professional. The most common misdiagnosis, probably about 70% or even higher, is to be diagnosed with depression. We think that one of the key reasons why that might be happening is because people do not recognize mixed elements within depression and misdiagnosing depression as mixed states, which, as I've said before, can have disastrous consequences. So I think we need to know more, that understanding mixed states could be a huge part in understanding how to improve diagnosis in bipolar as well.
Absolutely. And kind of a final question, because we're running a little bit tight on time. Where are you with this research? What are the next steps? And by saying you, I mean we, because I also work with people.
So I think that what we've done so far, did a large scoping review last year, which we're hoping to publish soon. And what this really shows is, what we know so far, and clearly making a much clearer sense of what we don't know and what we really do need to do as the next steps in research, what we need to find out. And we're hoping to publish that soon. But the sort of the real main next step is that we're hoping very soon we're preparing a large research project that's going to focus on trying to understand more about suicide in bipolar, but at the same time trying to understand much more about mixed states and about delayed diagnosis, looking at patterns, trying to trace patterns associated with mixed states, how this interrelates to delayed diagnosis, how it interrelates to people and suicide. And what we hope can, I mean, our aspirations, I think, to emerge from that would be, firstly, it would be fantastic to have some clearer clinical guidelines about what mixed states are and about how people can recognize them. We would like to have some really established scales so that people can measure a mixed state and measure its severity, just as we have established scales for depression and mania. We'd like to have scales that people can use themselves as part of mood tracking, so just to be able to have sort of a mood tracking chart, not just for depression and mania, but also for mixed states. And of course, ultimately, the hope is that from all of that we could move towards better treatment and better interventions for mixed states.
Thank you
And I'd
so
just like
much.
to say, if anyone listening today or anyone amongst the community, if you are interested in this area, if you're affected by this area, and if you want to become part of research into this area, please do contact us and please do, sign up for the community. We will be working on this area and it would be great to have as many people as possible involved.
Thank you so much, Tania. And I think we do have technically maybe a minute or two. And I just wanted to kind of open up the floor just for any kind of final reflections, if anyone had anything they'd like to say before we hand over to Eve to finish up for us.
Well, I would just like to say, Talen, that you've done a great job of chairing this session. So just thank you very much. It's really, really well done.
My first time chairing a session like this, so it was good fun.
Well, I would like just to echo that and just to thank you both, Jeremy and Tania. I learned a tremendous amount this morning or today from your presentations and the discussions then. So thank you. It was very informative.
And once again, just to say thanks so much to Jeremy and thanks to Melvin and Talen. You've done an amazing job and it's so fantastic to have you on board at Bipolar UK. Talen joined us in September and it has really transformed things, and it's fantastic to have her there. I do know that I remember that some questions came in from a couple of questions came in from the community about how to deal with mixed states as an inpatient. I don't think that we necessarily have time to deal with them right now, but I'd be very happy to, if people, I can send something out by email or add that to a newsletter. I'll remember to do that for those that weren't answered.
One of the things, Tania, that I would like to challenge you with is just the term mixed states. I think that it's as a term, it's woefully deficient, and I personally don't have any immediate suggestions as to how we should define these states. But I do recognize the challenges in this term, and we need to think more about how best to define or begin to define and describe these states, if you will, because
I couldn't agree more. I mean, one of the things that I wanted to say about mixed states is I think that essentially it's a misnomer. It's a name that doesn't fit the phenomenon, because they're not. As the moment that we say mixed states, everybody just thinks, well, you take a bit of mania and you take a bit of depression and you chuck them together and you've got one. But it isn't that. It's a very distinct entity, I think, in itself. And until we start thinking of it like that and start trying to characterize what actually is this, and even thinking what should we be calling it, I agree, then I think we've got a long way to go.
And Jeremy, I recall, I think that it came out of Cardiff, there was an editorial or a commentary that stated "mixed up about mixed states," if I recall correct. So I thought that was an excellent title to describe the confusion that we're all experiencing there.
And I can take zero credit for that one. I thought you were going to talk about the one, going, gone, the Kraepelinian dichotomy, which is the one that everyone mentions a lot. But no, I don't. Maybe that was Ian or Nick Craddock or someone like that. But it is a great title for a review. I'll have to go and look it out.
Sorry to jump in. I think we're now at time, so I just wanted to hand over to Eve. But thank you again, everyone, for joining us.